I'm Dr. Ajinkya. I'm going to present this case of uncommon cause of retroperitoneal hemorrhage following a coronary angiogram. I'll be presenting this case on behalf of our team at Avanti Institute of Cardiology, Nagpur. So, moving forward with the case, I have nothing to disclose. So, our patient was a 73 years non-diabetic hypertensive female. She had done her CABG in 2013. She had a mild AS at the time of CABG and decision was taken to leave it alone. Now, after almost 8 to 9 years, she presented to us with severe symptomatic AS, a normal EF, and she underwent a pre-AVR CAG. We did her femoral CAG. The native vessels were diseased and there was well-flowing grafts in LAD and PDA. We had used 3000 international units of heparin then. What happened post-angio, 2 hours later, she had hypotension and we thought it might be due to the pain at the femoral site. The sheath was already removed and sandbag was on her femoral groin, right? So we thought it was due to the pain, vasovagal type of hypotension, and it responded to IV fluids then. After 3 hours, her BPs was again in 80s and 90s, and this time she also complained of abdominal pain. Then we did her bedside USG, which showed a retroperitoneal bleed around the left kidney. It was good size, and we were suspecting that the culprit is high femoral puncture, which we as interventionists always fear of. So, but we were wondered and surprised because on CT angiogram, as you can see in here, the right femoral from which the puncture was taken was clear. There was no bleed from here, and this was the bleeder, if you can see, and this was the large hematoma encasing the left kidney. And the angiogram shows this bleeder, which was actively bleeding even during the CT angiogram. This was the bleeder. So, any random guesses from the audience, what might have happened? Yes, yes. Exactly, sir is exactly correct. It was a glide wire, Terumo, hydrophilic, and we were not in fluoro guidance. So, and we mistakenly pushed it into left renal artery, and then we fluoroed, we had resistance, we fluoroed and retracted it. Unfortunately, we don't have that cine of that time, and we did not even anticipate that this would cause such a life-threatening. We were so not sensitized that this could happen by a Terumo wire. By the time we did her CT angio and we took her to cath lab for embolization again, her hemoglobin has already dropped from 11.2 to 6 grams. And this in a patient with severe AS. She had a mean gradient of 50 almost. So she was already hypoxic. She was receiving blood transfusions while we were embolizing her. So this is the left renal artery embolization procedure. It was actually from an aberrant left renal artery. So we cannulated it with a 5 French SIM1 catheter. This is how we engaged that aberrant left renal artery. And then we saw, as you can see, the bleeder is clearly seen. The bleeder is seen. Then we selectively cannulated the lower branch of that left accessory renal artery with a Direczion microcatheter. It is just like the Prograde from Terumo. And after that, we had put 2 coils. First, we put a 3 mm coil, which did not stop the bleed. 4 mm pushable coil was advanced. Even still, there was some residual leak. Then finally, we put some 300 microns PVA particles that stopped the bleed. And this was the final angiogram, which showed the bleed has stopped. As expected, even after embolization, the course to her recovery was very stormy. She needed 4 transfusions, LVF, AKI, 5 days protracted course in ICU, and after 8 days of long stay, she was discharged. So this is the very easy step we usually miss during our procedure, that we don't advance the wire under fluoro guidance. And whenever that happens, cases like this will happen. So it is always better to advance the wire under fluoroscopic guidance, and if there is resistance, stop and see, do not push. And what retrospectively we thought that the first hypotension patient had, and we gave her IV fluids and waited for 1 more hour, I think that time could have been saved if we had been more vigilant. So all in all, the patient is doing well. She underwent a TAVR after 1 or 2 months then, and she's doing well at 2 years follow-up.